Yeah. Good morning, everyone. In a couple of minutes, I'll be taking the lecture we're supposed to have taken last week, but we couldn't due to some connection problem. So I'll talk about physiological changes in pregnancy. This is like the basics in obstetrics and gynecology. Yes, I'll talk about the different systems that undergo changes. Virtually all the systems in the body undergo changes during pregnancy. And this outline will be followed. So I was saying that pregnancy, which is the next step after fertilization, is a vital step that brings the fetus to the point at which it can readily function independently on Earth. So it's a process, and it undergo time and some changes. And also, at the same time, there are some maternal changes that occurred to adapt to these new tasks of nurturing a baby or the embryo till it becomes a full human being that can function independently. So I remember also said that pregnancy, the signs of early pregnancy, so the symptoms and signs. First of all, the woman will miss her period, and other things will occur: nausea, excessive salivation, vomiting, fatigue, frequent urination, breastfulness, hyperpigmented. These are due to hormonal changes or expression of hormone, pregnancy hormone, especially progesterone, estrogen, that leads to all these changes. Then there's also a signal or interaction between the fetus and the mother right from the implantation, mainly due to what? Trophoblast at the placenta bed. And also, these are the hormones that are implicated: the estrogen, the progesterone, beta HCG, growth factors, and other things that interact during that. So I'll move fast, especially where I've already covered last week. So we'll begin from metabolic changes. There's increased energy consumption in pregnancy, and the basic physiological process, there's about 66% increase in energy need in pregnancy compared to non-pregnant female. And this energy are used for secretion, thermoregulation, growth, and repair due to damage of the fetus, placenta, uterus, and breast growth. So these are where the energies are exerted. Then also, I also thought about the weight gain in pregnancy. In an average, a woman gain about 10 to 15 kilograms. And this is how the weight are being distributed: the fetus, the placenta, the amniotic fluid itself, the uterus itself increase in size and mass, then the blood volume, the breast size, and also by trimester, the increase is more in second and third trimester, about 5 kg each, while second trimester about 2 kilograms. Then we also talk about the protein utilization and need in pregnancy. There's also about 20% increase in dietary protein. 500 grams of protein will have been retained at the end of the pregnancy. 50% account for maternal gain, and also 50% by fetus and placenta. Then also fetus require little protein in first half of the pregnancy. Then in third trimester, in the 2/3 of required is acquired in the last 12 weeks of pregnancy. So this is how it's being distributed. So all these ones are just values to be noted in case of MCQs. And I also talked about carbohydrate metabolism and requirement in pregnancy, and the hormone that mediate how carbohydrate is being utilized. So and also talk about fat, and I also mentioned that at about 30 weeks, about 4 kilograms are stored. 4 kilograms are stored in the abdominal wall, and also back and in the thigh and the breast. Fat accounts for 2% of fetal weight at 32 weeks, and also 12% at term. So these are how fat is distributed. You may not really bother much about this. Also calcium. 40% of circulating calcium bound to albumin. Then also plasma albumin concentration decrease in pregnancy, hence total plasma calcium also decrease. There's little change in an unbound calcium, yeah, because the unbound calcium that is used for all the calcium metabolism. So then also there's also increase in gut absorption of calcium, and this is mobilizes calcium reserve. Then also there's also restrictive renal loss. These are all ways in which we want calcium to be available, because fetus utilize calcium for bone mineralization and development. So, but by and large, maternal serum calcium remain fairly stable and steady during the pregnancy. Okay, omega-3 fatty acids. So let me go. Yes, this iron is very, very important in pregnancy. If you look very well, one of the routine drugs we give in pregnancy, we give supplemental iron. And why? Because there's decrease in iron store in pregnancy, because most of the iron are being utilized by the baby for blood production, for red cell production and all. So that is why if you don't supplement iron, and because of our environment, the poor nutrition and all, if you don't give a supplemental iron, most people will be anemic. Most pregnant women will be anemic during pregnancy. That is why if you look at the routine drug we give in antenatal, iron is one of the key. So why? Because too little in diet, absorbed in ferrous form in the duodenum and jejunum, transported as transferrin, 10% ingested iron is absorbed. So because most of our diet contain little iron, and not all are even absorbed from the gut, only about 10% in the absorbed. Then the decreased serum iron, because of increased total iron bilirubin capacity, iron bilirubin body capacity, then it's stored as ferritin. So you have to know little thing about this. Is what is being transported as transferrin and is stored as ferritin. Then it is an active transportation. Iron is mostly passed to the fetus in third trimester. Total iron requirement is 1 gram. Fetus and placenta consume about 30 milligram. And red blood cells about 40 milligram during delivery because of the blood loss and all. Then, but the whole idea of the thing is that the iron requirement in pregnancy is 60 milligram per day. I don't think it's okay, it's here. Second half daily requirement 6 to 7 milligram. The reason being that I told you that about 10% of iron is being absorbed in the gut. So if you give elemental iron, if you give iron supplements 60 milligram per day, 10% of that is about 6 to 7. But this is the daily requirement. But looking at not all if you consume exactly 6%, remember that it's only about 0.6 that will be absorbed. So if you see us giving hematinics in pregnancy and all, this is the rationale behind it. Iron is the daily requirement is 60 milligram, but we actually know that it's about 10% that is absorbed. So in the actual sense, 6 milligram is what the body needs, why we give 60 milligram. Then now let's come to the system. We have talked about the dietary and some basic mineral requirement. Now let's come about our system. Cardiovascular changes in pregnancy is a major system that undergo changes. Virtually all systems, but the effect of pregnancy on cardiovascular system is very enormous. And the cardiovascular changes in pregnancy mimic those of the heart disease, because sometimes you won't think as if the woman, if you see a pregnant woman, maybe you pick some murmur, systemic murmur, or some loud first and second half sound, or you pick some diastolic murmur, you think there is abnormal in pregnancy. No, there are some cardiac conditions or cardiovascular changes in pregnancy that are normal. So first of all, there's elevation of the diaphragm. Yes, because of the increase in intra-abdominal pressure from the developing uterus. Because uterus change from being a pelvic organ to abdominal organ in pregnancy. So, and sometimes it can even increase up to the level of civistanum, depending on the number of gestation or other things. So it displaces the diaphragm up. This could lead to palpitation, adjustment of lung volume. Then the apex beat also can also be adjusted to the fourth intercostal space. There is increase in minute ventilation. All these things leads to breathlessness, sometimes because of the small lung volume remaining. And also there's increased total sodium and ion reabsorption. So that's why some pregnant women, they have edema and all. Yes, apart from the pressure effect and the increased venous return, there are also reabsorption of water and sodium in pregnancy. This is a bit to cope, to increase the plasma volume to cope with the circulatory demand in pregnancy. I also said that there's venous compression by the gravid uterus leading to syncope attack. There's also increased pulse rate. There's also possible systolic murmur. Just have said there are systolic murmur that are normal in pregnancy due to decreased blood velocity. There's also increase in left ventricle, right ventricle, and atrial diameter. Third heart sound from rapid diastolic feeding also occur. These are normal findings in pregnancy. Occasionally, you can also find fourth heart sound with left age position. So if you look at this, in fact, if you find this in a non-pregnant woman, they are pathological. Or non-pregnant patient, they are pathological, but most of these things are normal in pregnancy. That is why pregnancy itself has a great demand on the cardiovascular system. And that was the essence of all them in O&G after delivery. We want you to give you more time to recover. We advocate family planning, give at least 2 years inter-pregnancy interval so that your body can recover. Imagine after delivery, 6 months, you got pregnant again, all these changes repeated itself. All these things can lead to some cardiovascular disease eventually. Then cardiac output increased from 5 weeks and peaks at about 30 to 34 weeks, about 40 to 50% increase in cardiac output. Then after that, it became plateau. The cardiac output increased during labor 50% because of the, especially during the second stage where you need a lot of energy or you exert a lot of pressure to bear down during delivery. The cardiac output increased up to 50% in labor. So then mean arterial pressure increases. There's also increase in cardiac output due to increased blood volume and increased O2. So we all know that cardiac output can be calculated, which is due to increase in stroke volume times peripheral resistance. So then peripheral resistance about 15 beats per minute also increase. Then the blood pressure. How is the blood pressure during pregnancy? Usually, there is systemic vascular resistance decrease because of relaxation of smooth muscle during pregnancy. There is peripheral resistance, the peripheral resistance reduces during pregnancy. So this decrease in maternal blood pressure due to decrease in peripheral resistance despite increase in cardiac output. So in pregnancy, usually the trend is that blood pressure reduces because of decrease in peripheral resistance, despite even the cardiac output. But the overall effect is that the blood pressure decrease. So this is what I've said. There is overall decrease in diastolic blood pressure and mean arterial pressure by about 5 to 10 millimeters of mercury. Then also the antecubital venous pressure is unchanged. Femoral venous pressure is markedly raised, especially towards term because of the effect of the gravid uterus on the venous return. So the venous pressure, especially on the lower limbs, the femoral increase. So due to pressure of the gravid uterus on the common iliac vessel, and right, I've already said it. All these ones are just showing that there is increase in venous pressure, especially the femoral venous pressure. And this is why this is one of the risk factors of DVT in pregnancy because of the pressure, the stasis and all. So pregnant women, pregnancy is hypercoagulable state because of all this in addition to other factors. Then when you talk about central hemodynamics, the central venous pressure, there's no significant change. The mean arterial pressure and the pulmonary central wedge pressure, there's no significant change. Then there's what we call postural hypertension, supine hypertension syndrome, which occur in late pregnancy. That is why if you see a pregnant woman, especially as your pregnancy advice, we tell them to what? Lie on your left lateral position. Because if you lie supine, the gravity uterus is compressing on the inferior vena cava, which decreases the cardiac output, and this can cause supine hypotension syndrome because cardiac return is decreased. So we tell them to lie on the left lateral side because if you look at the abdominal aorta relationship to the inferior vena cava, inferior vena cava is on the right of the patient, while abdominal aorta is on the left. And if you know, the abdominal aorta is on the right, on the left rather, while inferior vena cava is on the, no, sorry, the inferior vena cava is on the right of the patient, while abdominal aorta is on the left. So if you tell the patient to lie on the left lateral, because the pressure in the artery is very high, the gravity uterus will not significantly affect the abdominal aorta because the pressure in the artery is very high, but in the vein is opposite, is very low. So if you lie on your back or on your right, you can press on the superior vena cava, which is on the right, and reduce cardiac output and can cause with cardiac syncope, hypotension syndrome. So there's also increased venous return due to blood squeeze during contraction. Cardiac output during labor increases by 2 liters per minute. Systolic blood pressure lowered, but diastolic is much lower in first trimester, or peripheral resistance decrease. I've mentioned this earlier. Then also the blood flow to the uterus. Look at it now, about 50 mils in non-pregnant state. In a non-pregnant state, about 50 mils per minute of blood flow to the uterus. But look at it in pregnancy, about 750 mils near term. That means in 5 minutes or in 5 to 10 minutes, the whole blood volume of a woman can be circulated through the uterine vessel. So that is why people, a patient that has PPH or any form of problem during pregnancy, they tend to have a fat. That's why PPH can kill within 5 minutes, because the whole blood volume can be circulated through the uterine bed within 5 to 10 minutes. Can you see from 550 mils per minute in the pregnant state to 750 mils? So there's a lot of high vascularity in pregnancy. The blood has to flow to the blood and to the uterus so that the baby can be perfused and all. Placenta and fetal placenta vasodilatation because of smooth muscle relaxing effect of progesterone, E2, nitrogen, and all. In pregnancy, vascular endothelium is refractory to angiotensin 2, endothelium 1, and other pressure. Then also pulmonary blood flow also increase. So uterine flow increase from 50 to 750 mils per minute. In the lungs too, there's also increase from 600 mils in non-pregnant state to 2.5 mils and 2.5 liters per minute in pregnant state. Also renal blood flow, the blood flow to the kidney in pregnant woman from 80 mils in a normal patient, normal woman that is not pregnant, to almost 400 mils. So all these values, please note them. They can come out in the MCQ. Blood flow through the skin also increase from up to 500 mils per minute. Then also increase accession and sweat and all. So now we are away from the cardiovascular changes. They are enormous. Now let's come to hematological changes. Blood volume increase up to 50% for 50% from the non-pregnant state. So I put here that progressive rise during pregnancy, though not consistent, increased vascularity, increased placental circulation. Blood volume start to increase at 6 weeks to a maximum of 40 to 50% of non-pregnant state at 32 weeks. Then after that, it stabilized till 10. That is blood volume. Then plasma volume also increased up to 50% too. So you just know that there's increase in blood volume, plasma volume also increase. Increase is more in multiparity or multiple gestation or large baby because of the obvious reason requirement. Then the red cells mass also increase, but because of the increase in blood volume more than the increase in red cells, there's what we call dilutional anemia in pregnancy. That is why hardly will you see, if you see a pregnant woman that has PCV of 40%, everybody will be shouting, "Ah!" You understand? Because there's what we call relative or physiological anemia in pregnancy. Why? Because the increase in blood cells, red cells, is not as rapid as increase in the blood volume. So the water is more than the cells. So that's why we say that there's what we call dilution of physiological anemia in pregnancy. That's why you have to support them with hematinics, folic acid, fesolate, and all. Red blood cell volume increased by 350 ml due to O2 requirements. Red blood cell mass increased from 10 weeks and up. Iron supplement increased red blood cell mass by 30%. So you see, what we are giving the supplement have up to 30% effect. Reticulocyte count also increased by 2%. Erythropoietin also increased. Then I've said that plasma volume is up to 40%. Then total hemoglobin increased by 18 to 20%. At 10 fall to about 2%. So all these things increase, but then the blood volume surpasses the red cells. That's why we have anemia. Then also the advantage of hemodilution. And this hemodilution, this physiological anemia, is to the benefit of the woman. Because what? We know that during delivery, the woman will lose some blood, no matter how small. So if there's no dilution, and the actual loss is actually cells, that means every woman that delivers will have to be transfused. But because there's already dilution, if a woman lose like 500 ml of blood during delivery or 400 ml, the amount of red cells there is not as equivalent as if a non-pregnant woman lose 500 ml of blood. So that is just it. So the advantage is to reduce blood viscosity, ensuring good gaseous exchange, because it will be, the viscosity will be reduce the effect of supine and erect posture, decrease actual blood loss during delivery. Can you see the effect? So nature has its way that even the physiological anemia, to some extent, is beneficial. Then also when we talk about the other part of the hematological changes in pregnancy, the neutrophilic leukocyte increase up to 10 to 50%. That is why if in the way you interpret full blood count in pregnancy is different from non-pregnant state. Usually the normal white blood cell count is 4 to 11,000 10 to the power 6. But in pregnancy, up to 15,000 is still normal. It's not sepsis. Except if there are other features of sepsis. But just merely seeing a white blood cell count of 15,000 in a pregnant woman is normal. Because unlike in non-pregnancy, anything more than 11 is say that is leukocytosis. No, in pregnancy there's still eating because the white blood cell count increase up to 15,000 and it's still normal. So all this have to be interpreted and also just apply with clinical features, except if there are other signs of sepsis. But just seeing white blood cell count alone of 15,000 is normal in pregnancy. Major changes in the immune system shift from cell-mediated cytotoxic response towards increased humoral and innate immunity. And the effect of this is so that the body can accommodate the presumed foreign body that the placenta and the baby pose. If there's no shift in the immunity, they will what we call rejection, and the baby there will be miscarriage and all. The total plasma protein from 180 is also increased to 230 and all. So then other part of the clotting factors, also there's some changes in clotting factor in pregnancy. I said earlier that pregnancy is an hypercoagulable state. Because of what? Fibrinogen increased by 50%. So an ESR, erythrocyte stimulation rate, also fourfold increase, though little diagnostic value. Platelet reduced in pregnancy by 15%. There's increase in clotting factor 10, 9, and 8, 7, and 1. Then factor 2, 5, and 7 are unchanged. Factor 11 and 13 slightly decreased. Protein C and S activity slightly decreased. All to maintain immune system. So all this thing is a way of nature. If this fibrinogen, like it encourages clot, if this is not done, imagine during the delivery now, there's the delivery of the baby and the separation of the placenta from the uterine bed. Imagine those spiral artery in the uterus. If there's no mechanism to put them in check, all the blood volume. Remember I told you that about 70 minutes per hour, 70 minutes of blood circulates per minute in the uterus. Imagine the whole 70 minutes, just for 1 minute, all the blood volume will just pour out. But nature has have it in that there's some physiological thing that immediately after separation of the placenta, the spiral artery begin to ligate during contraction, and because of all this increase in coagulation factors, they put them in check. If all these things are not in place, That means it's a disaster if a woman should deliver, because they will bleed to death. Then away from hematological changes, let's go to respiratory changes. Just I said that there's no system that is left behind during in the pregnancy. All system change. That's why pregnant women, they really undergo a lot, and I'm sure that for the married people among us, or the people who are parents and all, we have to really appreciate them, because they undergo. Imagine people that deliver 6 times, 7 times. Some people are para 10. Imagine that they undergo all this process every time. Some every year or every 2 years. So pregnancy itself is a great event that need to be well monitored and appreciated by people that undergo it. So the elevation of diaphragm, just as I said earlier, that because of the pressure, increase in intravenous pressure, there's elevation of the diaphragm up to 4 cm, decrease the volume of the lungs available for respiration. You understand? So respiratory rate is unchanged, though breathing is diaphragmatic. Tidal volume is increased by 40% because of hyperventilation, but decrease in late pregnancy. Minute ventilation increased from 7.25 liters to 10.5 liters. There's also the total pulmonary resistance is reduced because of progesterone effects. Subcostal angle increase. So these are some changes in pregnancy. You can go through them. The lecture will be available. Then vital capacity increase, residual volume increase, oxygen consumption increase, and all. Pregnancy is also a state of respiratory alkalosis and all. Then let's go to urinary system. The changes that occur there. There's because of the effect of progesterone on the smooth muscle, the ureter dilates, and also because of the effect of the pressure. Hello, am I audible? Hello, can you hear me?
Yes, sir.
Okay, all right, thank you. So, because of the effects of the progesterone, there is relative stasis in the ureter, and also there's dilatation of the uterus. So sometimes if you do a scan in pregnancy and you see some dilated ureter, it's not bother or worry. They are normal in pregnancy. The kidney increased by 1 cm in length. There's increased renal plasma flow up to 75%, which between 16% to 34 and 16 weeks to 34 weeks. Then the glomerular filtration rate also increased up to 50% because of increase in blood flow to the kidney. There's also increase in creatinine, blood urea, nitrogen, and uric acid clearance. Then decreased reabsorption of glucose, uric acid, and amino acids. And also the tubular reabsorption increased up to 50%. The ureter become atonic because of increased progesterone. I've said it look dilated. Then dilatation of the ureter above the pelvic brim with stasis more on the right because of the uterine descending rotation pressure, because there's what we call descending rotation of the uterus on the right. So maybe the effect might be more on the right. So the stasis is marked between 20 to 24 weeks. Then also elongation, kinking, and outwards division of the ureters, hypertrophy of the muscle. So these are some changes in pregnancy, but just know that there's increase in renal blood flow in pregnancy. There's also increase in glomerular filtration rate in pregnancy. Then let's come to GIT, gastrointestinal tract, or what we call alimentary canal. Then the gums from the mouth to the anus, we have to go through them. The gums are congested, spongy, and easily bleed. Understand? Then the teeth are prone to dental caries, gingivitis because of the raised cortisol level. And also there's decreased peristalsis because of the progesterone. That is why some people call it, they will come with constipation and all, because there's smooth muscle relaxation effect of the progesterone. So anywhere there's smooth muscle, it tends to relax. So the GIT is not left behind. So due to this, there will be reduced peristalsis and also lead to constipation. But because of the reduced peristalsis, any content in the in the GIT, in the bowel, tend to reabsorb because they are exposed more, they are exposed longer in the GIT. So there's increased absorption during pregnancy. And cardiac sphincter is relaxed because most of that is why it's common pregnancies. Last month, I have heartburn, I have this. Because of all this, there's the cardiac sphincter, that is the junction between the esophagus and the stomach. It's a bit relaxed. So there's a form of relative regurgitation, acidic irritation, and all. So if the pregnant woman comes with form of epigastric pain, heartburn, so GERD, gastrointestinal reflux disease, is also something that could happen. So nausea and vomiting, hyperchlorhydria, slow emptying of the gallbladder. So these are the effects of pregnancy on the GIT. Then when we talk about the reproductive tract, the vulva tend to be edematous, vulva vascular, labia minora, hyperpigmented because of the effect of the hormones. The vagina tend to be edematous, and there's increased secretion. Otherwise, these are some little changes. Then on the uterus, you should have a great changes. Non-pregnant state, if you measure the uterus, if you weigh the uterus of a non-pregnant woman, it's about 50 to 70 grams. And the males is about, the endometrial cavity will just take about 5 to 10 mils. Look at it. But at 10, can you see what weighs 50 grams or 70 grams can weigh up to 1 kilogram? That is 1,000 grams. And what can only accommodate 5 mils, 10 mils, can accommodate up to 1 liter. Understand? So there's a lot of hypertrophy, hyperplasia, and all of things that happen in the uterus. So uterus has 3 layers: the outer layers, inner circular layer, intermediate, and also the intermediate thinking, and which is the strongest crisscrossing, serving as a living ligature. Then also fundus enlarge more than the body, leading to lower attachment of the round ligaments of the uterus. Then the vascular, just have said that non-pregnant state, majorly uterine artery, less ovarian, but at pregnancy, the both contribute. We have 2 arteries supplied to the uterus from both uterine artery, which is the branch of the anterior, and the anterior branch of the internal iliac artery, while we have the ovarian artery, which also supply from the ovarian end, which is the direct branch from the aorta. So these are the 2 sources of blood supply to the uterus. In non-pregnant state, it's majorly the uterine artery that supply, then less from the ovarian. But in pregnant state, both of them contribute greatly to uterine artery. So these are the little changes. Then also there's what we call Braxton-Hicks, non-painful, non-dilating contraction in pregnancy, cervical change. So these are some of the changes in pregnancy. Fallopian tubes also undergo some changes. Ovaries, after ovulation, corpus luteum, sometimes they could cause pregnancy luteoma, fecal luteum cyst. These are little changes in pregnancy, so I have to move very fast. Then also on the musculoskeletal, the melanocyte-stimulating hormone from the anterior pituitary causes some hyperpigmentation. If you look very well, there's what we call some pregnant women have this dark line, midline from the cervicasternum up to the level of the pubic symphysis. We call it linea nigra. And then some people also have stretch marks, call it stretch marks, striae gravidarum. These are due to effects of melanocyte stimulating hormone, which cause hyperpigmentation around the umbilicus, nipples. And also, if you look at the nipple areolar complex of a pregnant woman, look hyperpigmented. These are things that these are what will cause it. And also on the face, some women have some facial changes, patchy hyperpigmentation and all, chloasma, gravidarum. So these are different changes that occur in pregnancy. Then also breast increase in size, majorly by hypertrophy, proliferation of the duct and alveolar connective tissue. Then secondary areola become obvious and all. Then in endocrine system, they are not left out. All the system, I asked earlier that all the system undergo changes. progesterone, which is produced by corpus luteum up to 7 weeks, then or up to 12 weeks. But from 12 weeks, the placenta take off the effect of progesterone secretion. Then, and progesterone is a great, one of the important pregnancy hormones that account for all these changes that I listed earlier. The causes produced by placenta level rises steadily in the pregnancy, about 250 milligrams per day. They release smooth muscle tone in the vessel, in the gut, in the uterus, in the ureter and bladder. They raise the temperature, they increase the fat storage, they induce overbreathing and breast development. Then also estrogen, also produced by the ovaries in pregnancy. Also placenta is also in the early pregnancy, but later the effect is taken over by the placenta. Then also they are the one that estrogen cause the growth of the uterus and breast via protein synthesis, H2 receptor, and reabsorption of sodium by the kidney. Then we also have human placental lactogen, which HPL, which is also called somatotrophin. They are secreted by syncytial trophoblasts. The level rises as the level of HCG drops, no effect on fetus, but their main effect is they inhibit insulin sensitivity. That is why in a non-regulated state, this human placental lactogen is what is responsible for what you call GDM, gestational diabetes. Because just as I've said that the pregnancy is a hypercoagulable state, also pregnancy is a diabetogenic state. What I mean by pregnancy is a diabetogenic state is that in normal non-pregnant patients, either man or woman, immediately you eat, yes, your glucose level increase. Then after your glucose level increase, the insulin is secreted from the pancreas, and it goes to the system because your glucose level will increase. Then, but the insulin will now come and cause the glucose to be reabsorbed. They will not stimulate the insulin receptors. Then the glucose will now be utilized into the system, the one that will go for store. Then, so that there will be normal glucose level in the normal patients. This is the normal thing that we all know. But in pregnancy, there is this human placental lactogen is now secreted to inhibit the insulin resistance, so that the insulin itself will not work as much as it is during non-pregnancy, so that there will be enough glucose available in the blood. This glucose available in the blood cannot be transported through the placenta to the baby. Do you get it now? So in a normal, that's why pregnancy itself is a diabetogenic, because like the body is a physical phenomenon that the body itself tries to inhibit the effect of the insulin on the insulin receptors, so that there will be more glucose available, because the baby needs the glucose. So the glucose will be high in the blood and be transported to the blood, because if the mother utilizes all the glucose, that means the baby will starve to death. So that's why I'm saying that, but there's a balance between how human placental lactogen inhibits insulin action and vice versa. But in an imbalanced form, the woman will not start having diabetes in pregnancy. So just know that. Maybe for those of you interested in ONG, when you come, you learn more about it. I've said that the human chronic gonadotropin, this is what, if you do a pregnancy test, either urine or blood, this is what we detected as positive or negative. Human placental lactogen, because immediately after implantation, the syncytial trophoblasts secrete human placental lactogen in the blood. So if you do a pregnancy test, this is what you detect. And this human placental lactogen, the effect is to signal the corpus luteum to start producing progesterone and all. So these are things, it peaks about 12 weeks to 16 weeks. Then later it became constant and disappeared after delivery. Pituitary hormone, all these are hormones secreted by pituitary gland, FSH, prolactin, and all. So they are all increased during pregnancy. Then the adrenal gland and pancreas, the cortisol, and all these, they are also increased during pregnancy. Then the thyroid thyroid, parathyroid gland, the T3 and T4 increase in first hour of pregnancy, T4 and T3 may decrease slightly. So these are the effects of all the thyroid hormone. So in conclusion, there are two types of normal physiological state in woman. One is in non-pregnant state and the other in pregnant state. So all these I'm saying now, if you call it the pregnant state, in the non-pregnant state, we call it pathological. But there are some things that if you see in pregnancy, you will not really bother. The whole essence of this is to adopt and adapt physiology in pregnancy state so as to keep mother healthy and also to be able to cope with the stress imposed upon her, which is nurturing the fetus that will lead to healthy delivery of a healthy baby. So this one, I just put some question here just to test our knowledge. In normal pregnancy, option A, blood pressure falls in second trimester. True or false? This is an interesting question now. Let's just use the next 5 minutes. So you can unmute yourself. Just raise up your hands so I can recognize you. And if you can also answer the question. In normal pregnancy, I can't see anybody hand though. Okay. Adasha, what is your take on this option A? In normal pregnancy, blood pressure fall in second trimester. True or false?
False, sir.
Justice Eboigbi. Okay. Okay. Anyway, option B, plasma volume.
False.
This is false. Plasma volume increase, not decrease. There's a reduction in erythrocyte production. True or false?
True.
Reduction? No, I say there's about 2% increase. False, yes. 50% of women have a transient diastolic murmur. They are not up to 50%. Yes, false. They are not up to 50%, about 20 or 30%. But this option A is true. This is the only true answer here. Blood pressure falls in throughout pregnancy because of the decrease in peripheral resistance. Okay, the answer here is all of that one are false except B, A, that is true. So the answer is A. Then the other one, it just there is 40% increase in renal blood flow. True or false? So anyway, by the time you check the lecture, you see the exact value. This thing can be confusing, but you have to know it. There's an increase in glomerular filtration rate. True or false?
False.
No, true. There's an increase in glomerular filtration rate because I said earlier that the renal perfusion, the renal artery or the renal circulation increase up to 50% or 7%. Then also the glomerular filtration rate also increase. So the answer, the B is true. The urea creatinine are higher than the non-pregnant states. That one is false. The upper limit of protein excretion in pregnancy is about 6 grams per day. That one is false. So I think the only option here is B. This A, that there is 40% increase in renal blood flow. It's more than 40%. The renal blood flow is up to 75, 60, 70, or even 80%. So it's more than 40%. Then, but the correct answer is B. But then, by the time you go to the lecture, you can see the exact values there. So thank you very much. So if you have any question, clarifications, let me entertain a few before we move on. Any question? So in absence of any questions, I think we can call it a day. So the lecture will be available as rightly said. Go through them And by the time we start some MCQ question, we'll still refer to this lecture for all the more questions that will come on this. So thank you very much. Okay, Dr. Okpaku.
Okay, thank you very much.